Osteogenesis imperfecta. Osteogenesis imperfecta, or brittle bone disease, is a rare autosomal disease that affects bone formation, strength, and structures of other tissues. It is primarily characterized by fragile bones that break easily. In fact, the term osteogenesis imperfecta means bone that was imperfectly made from the beginning of life. OI occurs equally among males and females across all races. It is estimated that 25,000 to 50,000 people in the United States are affected with OI. There are at least 8 recognized forms of OI. Many signs and symptoms are present in the condition of OI. Low bone density being primarily seen and responsible for the frequent broken bones from infancy through puberty. Spinal curvatures and ribcage deformities are commonly seen as well and can lead to abnormal posture, gait, and respiratory problems. Blue-tinted scleras of both eyes, dentinogenesis imperfecta, or brittle teeth disease, loose joint, ligament and laxness, and muscle weakness are common. Vision problems include myopia, and there is also a risk for retinal detachment. Basilar invagination is a serious neurological problem seen in some people with more severe forms. There are 8 recognized types of OI. The first 4 types are the most common. Type 1 is the mildest and most common form. While the structures of the collagen is normal, there's less collagen than there should be. There is little to no bone deformity. Height is less affected than in other types. Muscle weakness, joint laxness, and flat feet are common. Dislocations or sprains may occur as well as fractures. Life expectancy appears to be average. Type 2 is the most severe form. The collagen does not properly form. Infants are quite small and are usually born with multiple fractures, an unusually soft skull, and an unstable neck. Limbs may be small and legs may fall in a frog-like position. The head may be large for the size of the body. Almost all infants with type 2 die at or shortly after birth, often due to respiratory problems. Type 3 OI also has improperly formed collagen and often severe bone deformities. The infant is often born with fractures. People with type 3 are generally shorter than average. They may have spinal deformities, respiratory complications, and brittle teeth. Type 4 is a moderate type of OI. The clinical picture can be similar to type 1. People with this form of OI may be somewhat shorter than others in their family, have frequent fractures that decrease after puberty, and have mild to moderate bone deformity. Life expectancy appears to be average.
Children with osteogenesis imperfecta do not usually meet gross and fine motor developmental milestones due to a number of impairments. Repeated fractures require immobilization or surgery in some cases at a very young age, limiting the child to perform activities that should help them reach these milestones. Misalignment of long bones and joints, along with laxity in ligaments and general hypotonia, also cause difficulty for children to develop the strength and coordination to roll, crawl, increase sitting and standing balance, develop object manipulation, and so on and so forth. Cognitive milestones are least affected in children with osteogenesis imperfecta, as PTAs will be working to meet gross and fine motor developmental milestones to help improve quality of life in these patients. The patient my partner and I were given the opportunity to observe presented with the typical signs and symptoms of osteogenesis imperfecta, with the short stature, barrel chest, misaligned long bones and joints, except without obvious hypotonia, which only became obvious while performing exercises. From the information seen in the patient's file, the initial evaluation given by the PT implied that increase in coordination and strength were to be reached in the short-term goals. Functional activities like gait pattern, jumping, hopping activities, and walking backwards to improve coordination were performed in treatments to also help the patient be more functional in the community and while performing transfers and ADLs independently. So there was an expectation to grow from baseline evaluation.
An example of evidence-based research provided by a PTA or PT is the application of aquatic exercise for the purpose of improving the effort and movement capacity of children suffering from OI. This study also aimed to increase self-confidence and tone. This study lasted 60 weeks with 1-hour sessions for 3 days a week. The weekly treatment consisted of 1 technical training, 1 volume training, and 1 specific strength training. The results demonstrated an increase in the child's exercise capacity, endurance, and provided an ideal environment in preventing the child from any form of fracture throughout the course of treatment, which was reported to be regularly happening before the implementation of the study. There are numerous treatments for OI, and many of these treatments are used in combination depending on the type and severity. Physical therapy is used to maintain and gain as much function as possible. A treatment plan usually consists of muscle strengthening with aerobic conditioning. Target muscles that are strengthened include the deltoids, biceps, and important lower muscles such as the gluteus maximus, gluteus medius, and trunk extensors. When these muscles are strong, children can lift their arms and legs against the pull of gravity and get around independently. Wearing braces on legs can provide support for weak muscles, decrease pain, and keep joints properly aligned. Braces can allow people to get around and function more easily. Some people with OI undergo surgery to correct bone deformations, including scoliosis and basilar invagination. A common surgical procedure is rodding, which is the placement of metal rods in the long bones of the legs. This strengthens them and helps prevent fractures. Some rods get longer as the legs grow, but they also can work their way out of bone. Surgery can also be performed to improve hearing loss. Bisphosphonates are drugs used to treat osteoporosis. They're also useful for OI, especially in children. These drugs do not build new bone, but they slow the loss of existing bone. They have been shown to reduce any kind of compressions and some long bone fractures. Due to brittle teeth, dental work such as crowns and similar dental devices are needed. Hearing aids for hearing loss, and oxygen administration for people with respiratory problems.
In conclusion, it is important to be familiar with the symptoms, precautions, and expectations for growth in children diagnosed with OI. For obvious reasons, handling techniques must be mastered in order to prevent fractures or prevent worsening misaligned joints in the children that we may work with throughout our careers as PTAs. It is important to keep in mind that while working with children who have been this way since birth, we must not make them feel different or self-conscious about their condition. Instead, we must instill in them the education of important guidelines and tips to help them be as independent as possible. Just as important will be showing them that through treatments we can help them live a higher quality life. Something my partner and I learned from our trip to Wiggles was how building that relationship and trust with your pediatric patient will also help them be all in with what the PTA is trying to accomplish. It was a refreshing experience to be a part of.